Hello, my name is Joseph Medina, and today we're going to be performing 5 different positions on my little nutcracker patient here. So for the first one, we're going to be doing a trauma cervical spine. And as protocol for cervical spines, the patient has to have a C-collar, which is the white one we have on him right here. And the CR would be a horizontal beam to C4. And the criteria would be that the patient has to have a perfect lateral to ensure there's no rotation through C7 and T1. The anatomy demonstrated is just the C7 through T1 vertebra, and the KVP for this would be 75 to 85, and the patient cannot move during the whole procedure, so you have to work around them. For the next position we're going to be performing is a pediatric abdomen, so you can ignore his facial hair and pretend he's a 6-year-old kid that needs an x-ray. The CR for this would be 1 inch above the umbilicus. The criteria would be the vertebral column centered with no rotation of the hips to ensure that the patient is properly aligned on the table. And the anatomy demonstrated would be the entire contents of the abdomen, gas patterns, and air fluid levels with the soft tissues, and the diaphragm and the symphysis pubis have to be demonstrated just to ensure you got the whole abdomen, and the KVPUs would be 65 to 75 for children. For the next position we're going to be performing would be the hip infero-superior hip, or the Danielus Miller. So for this patient, we did have to improvise because we cannot keep their leg up by themselves. The CR for this would be perpendicular to the femoral neck of the leg of interest, or the hip of interest, and to elevate the opposite leg so you're able to have a clear view of the cross table CR. Anatomy demonstrated would be the hip of interest, and to see the joint between the pelvis and the femur. And the KVP for this would be 75 to 85, which is kind of low because since this other leg is out the way, you don't have to use as much penetration. The next position we're going to be performing is the RAO barium enema. So the CR for this would be perpendicular to 1 inch to the left of MSP, and with RAO, they're facing down with their right side down and their left side up. The criteria for this would be their spine parallel to the edge of the IR. The right ala of the right ilium is foreshortened and the left side is elongated, with the right colic flexure shown. And the anatomy demonstrated must be the right colic flexure, and ascending colon and sigmoid colon have to be seen open without superimposition to ensure that the patient is correctly positioned. And the KVP required would be 80 to 90. And here we have the little BE tube because the patient is going to have contrast inside, so you have to make sure all the flexures are shown properly even with the contrast. For the final position on my little nutcracker friend is going to be the LAO esophagram. The CR for this would be T5 or T6 to ensure that you get the top half and the bottom half of the esophagus. The criteria would be that the esophagus has to be free of superimposition, which is why we have them in LAO, because otherwise the spine would superimpose the esophagus and they will be swallowing contrast. So being free of superimposition is necessary. The anatomy demonstrated must be the esophagus seen between the hilar region of the lungs and the T-spine, again having to do with the superimposition, and the KVP used would be 110 through 125.